Welcome everyone to the second day of the Virtual Innovation Summit, brought to you by Lenovo Health, Intel, and Becker's Healthcare. We are pleased to have you all here for today's webinar presentation, How a Unique Health Safety Identifier Will Help Providers Achieve Value-Based Care. We will begin today's webinar with a panel discussion, and we'll have time at the end of the hour for an audience question and answer session. We are pleased to have Scott Becker, publisher of Becker's Healthcare, here to moderate today's panel and question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. Finally, we invite you to join the conversation on Twitter today using the hashtag InnovationSummit17 to continue the discussion even after the webinar has concluded. At this time, I'm thrilled to introduce today's panel. We have Jake Dorth. He's the Chief Information and Innovation Officer at Tahoe Forest Medical District. We also have Frank Desano. He is the former Chief Information and Strategy Officer with St. Peter Healthcare System. We also have Tom Foley, Director, Health Solution Strategy with Lenovo Health. And we're also joined today by Catherine Schulten, who is the Vice President, Product Management with Life Med MD. Scott, I'll now turn the floor over to you to begin today's discussion.
Thank you very much. Before we get into the gist of the discussion with Jake, Frank, Catherine, and Tom, I'll just give a quick background on unique health system safety identifiers and some of the challenges that people are having. The truth is that most healthcare organizations have found duplicate records, medical identity theft, and payment fraud to be some of their bigger health IT hurdles. They contribute to revenue loss, medical errors, and patient dissatisfaction. I've had the pleasure recently to have discussion on the same topic with Jake Dorst, who's on the phone, and just how much can be achieved by improving how systems handle patient ID and making it more systematic. In the age of value-based care, these challenges can be magnified. During today's webinar, we'll talk about patient identification barriers that slow the transition to value-based care and other challenges, and also how establishing a unique patient identifiers and a master patient index can help. So with that, I'd like to start with a question for Jake and Catherine. And Jake, I'll have you go first. And Jake's the CIO and Chief Innovation Officer at Tahoe Forest Medical District. You've also had the chance for an interim period to serve as leader of that hospital. Jake, why is patient ID important for providers, particularly in the shift to value-based care? But just to make sure, both in and outside value-based care, why is it so important?
Well, I think, with value-based, first of all, thanks for having me, and I appreciate the opportunity to come back and talk some more to your listeners here. But, I think the most important thing in value-based care is you're asking all these physicians and caregivers to do these extra steps to take good records, to make check off the boxes to meet these goals. And if you've got duplicate records, then you're kind of hobbling it from the beginning. So it's very important to make sure that you're doing all of this additional work and doing it to where you're going to be able to get credit and show the progress on the back end of it. I mean, in a short way of putting it.
And Catherine, the same question: why is patient ID important for providers in the shift to value-based care? And then also, just quickly, some of the problems you see where parties don't have patient ID correct, where they have challenges with it. Catherine, I'll let you start, and Jake, I'm going to come back to you very quickly on that.
Thank you. So value-based care is, we're entering into a brave new world here about how we're going to be accountable for the revenue cycle and the documentation around patients. And no longer is it appropriate just to have a single slice of the patient's episode or of their record. Value-based care requires this 360-degree perception of the patient's care for an episode. And that mandates that we have what I've heard called data liquidity, or the ability to easily exchange and seamlessly exchange this patient's record with other providers involved in the patient's treatment. And, you know, that's hard enough today to accomplish that within the enterprise. You know, imagine these situations where the patient has multiple providers across multiple enterprises, or even the more complex situation where you have the snowbird and the patient receiving part of their care half the year down in Florida, and you know, the other half of the year up in Massachusetts, for example. You know, how are we going to be able to easily exchange this information and really know that we are asking for, exchanging, and receiving the records all on the same person? And this is complicated, as Jake pointed out, by the fact of duplicate records. That also makes this a huge challenge.
And let me move on to the next question, which is for Frank and Tom. Some of the biggest barriers related to patient ID. It seems to a layperson, patient ID should be the simplest thing. What are some of the big barriers on it? And obviously, that's almost a plant question, because I realize even though it seems like it should be so obvious, I've gotten an education on how much trouble comes from improper tracking of patient IDs and missed patient IDs and so forth. But what are some of the big barriers? Frank and then Tom.
Well, again, thank you, Scott, for having me. So let me say that first. Getting right down to it, I think some of the big issues are, you know, the fragmentation of care. So as that continues and we see care migrating from inpatient to outpatient to retail, I mean, there are more and more players, so that makes it difficult unless someone steps in. I think, you know, privacy and identity theft are concerns, so lay people may say, why not? But at the same time, people are really concerned about privacy, particularly when it comes to, let's say, care for HIV or mental health. And then I think the politics are involved in this. You know, people that see this, any kind of national identifier, as a step towards a single payer system. I think those are the main things from my standpoint.
And Tom, some of your thoughts on the same question, some of the biggest barriers related to patient ID. Let me just see if I've just lost Tom there for a second.
I'm back.
Oh, thank you so much.
I apologize. So thank you for having me on the panel. But to address the question, I think the challenge to adoption of patient ID in some part comes in the needing to challenge current workflows and processes on a number of different fronts. You know, when we talk to clients, when we talk to them about patient ID, it's often, we don't have a patient ID problem. But if you ask them if they have a duplicate record problem, a medical identity theft problem, a payment fraud problem, and a data quality problem, they have that problem. I always go back to a response that we got in a focus group on this topic, and a CIO of a large institution said, I never thought that those problems were solvable. They're solvable in the context of a patient ID. So value-based care is the ability to reduce your operational costs as well as increase the value and the outcomes of a patient's wellness. So the need to challenge processes and look at alternative ways and more efficient ways, more cost-effective ways to improve the quality of care, I think is a huge barrier in the process.
And Tom, let me just ask you a very brief follow-up on that, or for you to re-summarize something you said. When you talk to CIO, they start with, we don't have a patient ID problem, but you explained, even though you might not think you do, here's the 4 or 5 consequences of not having this perfect. Can you just go through that again and explain how that sort of interacts, how those intersect?
Yeah, so the duplicate records, you know, when I transition a patient of care from one system to another, from one setting of care to another, let's just assume they have different EHRs. Each EHR identifies me differently, so when I send that document over to that next setting of care, the EHR is going to say, I don't recognize that patient. It's either going to go into a manual reconciliation queue or automatically say, hey, I don't recognize that I'm going to insert a new patient. But now you have but the patient was there. The system just didn't identify it properly, and therefore we create duplicate records. And there's other reasons why we create duplicate records as well. So the health systems spend a lot of money manually reconciling duplicate records in the back end. And I always say that that's a problem in and of itself. And the problem is that if I got 2 Tom Foley's in the system, I can't manually merge them as an IT process, I have to know factually that it's 2 different Tom Foley's or the same Tom Foley. And medical identity theft is all about duplicating someone's identity. So you don't know using that. So an identity, a unique identity, and the ability to bring your identity with you across the setting of care, regardless of EHR or of EHR, helps solidify that particular problem.
Thank you. Catherine, a question for you, and then Frank and Tom on this question. What methods are being explored to establish a unique health system identifier? And just, again, for a layperson, and Catherine, you could start with this, what exactly is a unique health safety identifier? How is that different than a social security number or something like that? And then what methods are being used to establish these unique health safety identifiers?
Sure.
Catherine?
Yeah, so this is, one of those topics that we could sit around all afternoon talking about this one question. So let me distill it down to just a few basic things. There is a lot of momentum in the industry today about ways to improve this identity challenge that we're facing. We see it manifest in groups like CHIME. We see it going on with the ONC, studies around things around patient matching, better ways to get to a higher degree of certainty that we're talking about the same person. But those are really sort of a false flag or a false start, because really we're not establishing identity. What we're doing is matching like for like. We're saying this first name matches that first name, gender, date of birth, address. And so if all of these details line up, then I feel confident that that's a match. Well, yeah, you have a match, but you don't have a strong identity. And identity is about identity proofing, knowing that this person really is who they claim to be. And while that is a topic that we've seen in banking, the whole concept of know your customer, we don't see it so much in healthcare. And that's a problem. And in fact, just this week, there was an agency that had published a document around cybersecurity. And one of the recommendations they gave was around the need to get stronger and clearer on the identity of the patient. So we see momentum from within the industry, from the federal sector, that these are things that we need to start looking at and investigating. A unique health safety identifier is not the same thing as a social security number. Those are ID numbers, strings of digits that can be transposed, that could be stolen. That's really not what we're talking about here. We're talking about a federated ID system, a health safety system that not only ensures that we know who the person we're talking about, but it's a federated identity that can be exchanged within an enterprise, across enterprises, and runs using established guidelines and recommendations. And there are standards out there for this. So that's really what we're getting at.
Got it. And Frank, some of your thoughts on methods being used to explore and establish unique health safety identifiers.
Say that 3 times fast, right?
Sorry about that. Yes.
I agree with Catherine. I mean, I think a lot's being done on the periphery, whether it's organizations like CHIME or, private organizations that have tried to do it in the past, like Apple and Microsoft and others. And I think she hits the nail on the head when she said that these are still about, matchy-matchy and not setting up a unique identifier. And I think, a unique national identifier is basically the element of any real solution about this. And when you look at some of the other methods, even Kaiser admits in print, Kaiser Permanente, that within their own system, they can only match records with about 90% accuracy. So imagine some of the challenges we face when we go outside of that. And as far as Social Security, I mean, you could just start with the fact that not everybody has one. And, you know, there's a lot of theft there of Social Security number and things like that. But just start on the basis of the fact that not everyone has a Social Security number for a variety of reasons. That really can't act as a sole singular identifier when it comes to patient and national health.
And Tom, anything to add on methods that are being explored to establish a unique health safety identifier? Any thoughts, Tom, that you could add to this?
Yeah, so I want to build on what Catherine had indicated in that a unique health safety identifier is not a alphanumeric number that you can view. One, it's not viewable, one. And two, if we take a look at some examples of how a unique identifier might have been attempted to be established in several health organizations. One, you know, a lot of health organizations use biometrics. You come in, you put your palm vein down, and and you now attach that palm vein reader to a medical record. But to Catherine's point, if you didn't identify the person to begin with, the palm vein reading is not an accurate conclusion as to that person being who they are. Duplicate records. Again, I come in with one palm vein. I'm Tom Foley number one, and the real Tom Foley comes in. He puts his palm vein down. He gets attached to his own other duplicate record, and so we never solved any problem on the duplicate record front. So you perpetuate a medical identity theft analogy. So a unique health safety identifier is a reference point that has dual factor authentication as well. And so one, you need to be identified per the ONC guidelines through NIST level of assurance 3 is the target, and then establishment of that identity, and then putting together a dual factor authentication towards that is really the proper approach towards establishing that unique identifier. And then from there, I can bring that across the continuum of care regardless of the EHR in which I'm currently in relative to a specific health institution.
Got it. The biometrics point and why biometrics itself, sort of how we sign into the iPhone today or something like that.
Right.
Why is that? Did you just explain again? Why is that? I mean, I know it becomes pretty obvious as you think about it, but again, very quickly, why is that not itself an effective approach or the only approach you got to use?
The fundamentals of a unique health safety identifier is the ability to be identified, to be identity proofed first. And it's like the current way is I give my driver's license and my insurance card to someone, and just because it's the same picture on the driver's license, people assume it's me. But I've never really been identity proofed. Same thing holds, and hence why medical identity theft is so prevalent. And the same thing holds true with a biometric. I hand my ID, but there are fraudulent documents, which we know is prevalent in the industry, and I put my biometrics down. I haven't been identity proofed through a proper channel to validate I am, in fact, who I say I am. Once you do that, then you can collect the biometric, because now I have my identity established. I have dual factor authentication, which would be it could be a biometric, it could be several other types of tokens to give you that dual factor authentication. So when I check in, I present my token, whether it be on a chip and pin type of card and a biometric, then I can have confidence that my data is, I am who I am, and I am associated with a specific data record that is only about me.
Got it. Thank you. Thank you so much. And Catherine, next question I'm going to ask you and Jake. Why is an enterprise master patient index, why is that not enough? Why having that master index is not enough?
Sure. So An EMPI is an absolute necessary service. It supports the record matching within the enterprise. It's useful for duplicate record detection, for remediation of a duplicate, for investigating overlaid records and unwinding them. It is something that absolutely complements the system that we're describing here. So while an EMPI is very useful, I would never, toss that baby out with the bathwater. It's necessary within the enterprise, but it is not the end-all be-all. It is a service that serves to match records, but it is not a service whose role it is to identity proof or establish authenticators, otherwise known as tokens. So it needs to be, at this point in time in our industry, it needs to be supplemented with the design that we're discussing here today.
And Jake, anything that you could add to that? And you guys have adopted a system using some of the technology being talked about on the phone. What are some of the reasons why just the Enterprise Master Patient Index is not enough, or the point of an MPI number? Why is it not enough to use to identify patients and know and connect them all?
Well, I think what Catherine said is, I think Johns Hopkins found that 92% of their duplicate records happen at the point of registration. So, and they, having an EMPI doesn't solve that issue. So what we need to do is what we've done here is we have a card. So when folks come in, we've matched them, we know who they are, and then that propagates through our system. No matter what point of entry they come in, we have these devices that can read. And where we talked about biometrics, if you lose your card or if you don't have your card, we can identify you that way. But it's more like the TSA pre-check, kind of where we know who you are. You go through those steps, and we've correctly identified you as Jake Dorst. When you bring that card in, then I know it's you. And I think that's where, when you look at an EMPI, it doesn't have that positive patient identifier on the front end. So it's more about matching. But I think it is, Catherine's right, it's a marriage of those two, I think, is the fix.
Yeah, so you need both. You can't be one
Right.
without the other. You got to have both, but
Right.
that's just not enough. This is your TSA start, but then you need the card and whatever else it is to get to the next level to make sure everybody's in sync and together.
Right.
Yes.
And
You got
especially if you have disparate systems, your EMPI is going to really help, propagating that correct identification of that individual throughout your system.
Gotcha. And Frank, unique health safety identifier solution, how does that help enable greater interoperability in terms of interconnected EHRs and data sharing? Why is this an important answer? And any examples you see of it, either at your former health system or systems you've worked at, or and so forth. And then Tom, I'm going to ask you the same question.
Well, I think, as we've gone through this discussion, Scott, I mean, it becomes, obvious about the advantages, and I think they occur on several levels. I mean, without getting into the weeds, I mean, I think the reduction in errors and the reduction in overhead expense with doing all this patient matching, which I think we're saying the best people in the business are around getting it right only about 90% of the time. So, I mean, I think there's a huge issue there. From a delivery perspective, it's going to reduce cost by eliminating duplicate tests that are ordered and incorrect diagnoses that are based on incomplete information. So it's going to lead to better patient care, less patient errors. Less patient errors are going to not only afford a better patient experience for the patient, but certainly going to cut expenses on the healthcare side as we go to value-based payment and go at risk. So, I mean, I think all of us could probably talk about this for a long time, but I think the benefits are huge from an administrative perspective, a patient care perspective, and I probably just touched the tip of the iceberg here.
And Tom, some specifics or thoughts to add to that in terms of how a unique health safety identifier helps enable greater interoperability and better connection amongst EHRs and better data sharing.
So I just want a point of clarity on interoperability. I don't necessarily believe that the industry, while they talk about having a problem, I don't believe we have an interoperability problem in the context of we can share data. There are more than standards than we can bear to use. So we can push data, consolidated CDA from one EHR to another. That's not necessarily the problem. The challenge is the semantic interoperability, understanding the data. And that is really the key relative to success here. And it goes along the lines of your previous questions. You know, an EMPI is really a probabilistic matching algorithm. And as we've said, and many studies have validated, you know, they're about 90% effective. What a unique health safety identifier does as we move from volume to value, and we transform and bring in innovation, is that it moves us to a deterministic matching algorithm. So when I share data from one system to another, it's a very deterministic match. You either are or aren't. You don't have a rating system relative to a probabilistic matching algorithm as to whether or not it's the same person. In value-based care, yeah, and regardless of value-based care, we should have 100% confidence that when we share data and when we add data, we merge data, that it is absolutely associated to one and only one person. Today, we don't have that confidence, and therefore, as well, I would add a unique health safety identifier goes further in eliminating many problems that CIOs, CTOs, CMIOs thought they could never solve. Duplicate records, medical identity theft, payment fraud, and ultimately leading to better data quality. The more you have better data quality, the better the clinical decision support you'll have.
So you had said something there, and you had said, because we don't have a unique health system safety identifier, unique patient safety identifier, that we end up in a spot where we almost have to double and triple check to make sure we got the right records, the right patients. Is that what I heard you say?
That's right. We know in speaking with several health organizations that they spend several $100,000 a year, if not more, going through this validation check and therefore and also the elimination of duplicate records that they have in their system.
Gotcha. So the better and better you get at this and making sure you could clearly identify a patient at all times in all places in the system, the less follow-up, manual work, other kinds of work that has to be done, checking, double-checking, verifying, and so forth. Just at the end of the day, long-term streamlines getting to work and doing what has to be done for the patients.
Absolutely.
And also reduces theft, fraud, other types of problems.
That's correct.
Fascinating. Got it. Okay. Thank you. I'm going to ask each of the following questions. And some of this has been touched on already, but if each one of you can give me some thoughts on this. I love moderating these webinars because I myself end up getting an education. I hope our audience does as well. But here's a question for that. What are some of the other benefits of a unique health safety identifier beyond value-based care? I mean, taking value-based care aside, and all these things become trickier and more important in value-based care, especially the amount of handoffs from place to place and the financial handoffs from place to place. But even outside value-based care, maybe Tom, Catherine, Frank, and Jake, I could ask all of you to talk about some of the benefits of a unique health safety identifier solution or unique health safety identity.
Yeah, so if you want me to take that first.
That'd be great.
So ultimately, the benefit is the patient experience. From check-in, registration, all the way through to the value of the care in which they receive, is all can in large part with a unique health safety identifier be a huge contributor. Again, because we have, and that I say that in the context of better data quality at the point of care. That's ultimately what we're trying to get to. It's not about the identifier. It's about how do we get to a better data set at the point of care and to be able to treat that patient accordingly. And the less errors that we make because we have better data quality ultimately leads to better outcomes at a reduced cost.
Great. And Catherine, same question. Some of the benefits And maybe you could give some background on what you do to help the audience understand a little bit more of your perspective on this too, and how you approach this.
Sure. So I'm the product manager over at LifeMed ID. We're a company that actually works in this space, and in fact, most of my career has been spent in the trenches on patient identity, working in this role and then at other vendors as well. So this is a topic that's very close to me. I would say that the answer here for me is patient safety. That is ultimately the biggest goal that we get out of accurate patient identity. We need to avoid these situations of commingling data, getting a father and son's data mixed up together because they both have the same name and they both live at the same address, or twin brothers who live at the same address and their data gets commingled because one's name is Tim and the other's Tom, and they're one character off and their data gets commingled. I mean, these are life events that if you get the data wrong, you could actually cause harm. Reduction in duplicate tests. When you can't find the MRI or you can't find some lab result, the test is ordered again. That actually can result in a patient safety issue. So to me, if we get the identity challenge right, we can help to avoid some of these patient safety concerns.
And Frank, your thoughts on this?
Yeah, I mean, I agree with everybody that spoke previously about it. I think, a big outcome of this ultimately is it brings healthcare closer to the patient. I think having a national identifier and making it easy for the patient to even aggregate or have access to their own information is going to allow them to take a more active role in their care. That's going to also help with reduction in errors, reduction in cost. So I think there's a patient empowerment aspect to this as well. And as it gets easier to access and aggregate that data, people will be more likely to use portals and things like that, where they can have one point of entry into all their medical history, and they can use that to drive care with their providers.
And Jake, you've actually implemented a system along these lines or in the process of doing so. Some of your thoughts on why this is helpful and what are some of the benefits, outside of value-based care, inside or outside of value-based care? What are some of the usefulness or benefits that you're seeing?
Well, coming from the hospital side, I first have to really agree with, our reason for putting it in was patient safety. There's things out there now saying that the third leading cause of death in the U.S. is medical errors. And, two things can happen. The duplicate record that we're talking about can, you get extra CT or something like that, where you get extra radiation. But if you have an overlay, like was mentioned earlier, you can actually have the wrong blood type or more allergies, things that are much more dangerous. So that was our first reason for putting this in, as well as the cost that we were spending on tracking down these duplicate records, and just the embarrassment of the billing errors if someone came here that didn't have service here and is getting a bill in the mail. That kind of reflects poorly on the hospital. People, if you're not getting your billing right, then how are you at everything else? But I think there's another piece that we looked at in a very competitive market. This is a way to stand out, and we were able to actually brand the LifeMed ID product, the EMPI product, to our Blue Life program that we use. We actually branded the cards that way, and we use it as a brand awareness campaign, touting that we're going to get it right, we're going to be safer than the others, and we're also looking at the card as a loyalty card for businesses in our community. So there's other things you can do with the program if you leverage it right, and that's something that we've done and we're quite proud of.
So you felt like you needed this to improve patient care, reduce theft, improve protection against fraud, and on top of it, you've been able to turn it into a positive for the system in terms of identifying with the system in your patient community. Is that a fair assessment, Jake?
Yes, sir. That was our goal, and I think that it gave us a platform, one, to really show folks that we care and we're trying to do the right thing as far as patient safety and be the best that we possibly can, but also have it reciprocal to come back to say, hey, these guys are really pushing patient safety and they care about us, as opposed to some of our competitors who aren't there with this type of program yet.
Great. We've got a couple of audience questions, and I want to commend Tom, Catherine, Frank, and Jake. And just as you answer the first audience question, if you wouldn't mind doing me a favor and just giving one bit more background on your role and what you do, just so people get some context and can identify with you a little bit further, would be great. So I've got a first question is, how does this work, patient identifiers, as the world moves towards things like telehealth visits? Catherine, maybe I'll start with you and then go to Tom, Frank, and Jake. If you want to tackle this question, unique health safety identifiers in the telehealth area, are there different challenges? How does that work? And Catherine, if you couldn't just give, you already did give some background in the last question. I'll ask Tom to do it. But if you could just tell us your thoughts on the question.
So telehealth is an absolutely fantastic question, because this is where the industry is headed. More and more patients are going to be getting their service in this fashion. And it's one thing to identity proof and provide some sort of identity token when you are physically present, because maybe there's a reader available, so you could do a biometric there on a palm vein scan or fingerprint reader. And you can provide your driver's license to a person, but how do you do this in a telehealth environment? I'm sitting at home and I'm going to reach out and contact a new provider who I've never seen before. How will I be identity proofed? How will I be known? And a solid identity solution actually can address the remote patient, the patient who's not in the clinic. So we can solve that today. We do solve that today. There are biometrics that are appropriate for a remote scenario. So facial, voice, these are all excellent biometrics when you have maybe a web camera available to you or your own smartphone. There are processes involving like text messages that are sent to your mobile phone and you reply back with a PIN code, those sorts of things. So there's all sorts of ways to promote a telehealth experience, even so far as to doing the identity proofing in a remote experience, providing your driver's license, et cetera. It's necessary to use things like your smartphone camera and other enabling technologies. But if you're looking at a vendor who works in the identity space, these are all things that they should have solved for and can also apply.
Gotcha. So these are all questions and issues that are very much in the purview of what companies like yourselves are really looking at and studying and always constantly figuring out.
Exactly.
Is that a fair assessment?
That's exactly right. Yep.
Got it. Let me ask Tom, just one moment of background on yourself again, and then if you have any thoughts on the telehealth issue that you wanted to add as well.
I do. So my role here at Lenovo Health is responsibility for their global health solution strategy. So we look at this in a context, not just what happens in the acute care setting or ambulatory setting, but we look at how the consumer needs to engage as well. And telehealth is actually a very interesting prospect. So, and I'll expand that into, with value-based care, the home is becoming a setting of care. And this is one of the reasons why unique health safety identifier is so important as we move forward, because we need to get it right in the current construct, but as we expand outside of the brick and mortar of health facilities and into the home, we have to do a much better job on ensuring that the patient that you're talking to is in fact the patient, whether they're remote or standing right in front of you. So everything that Lenovo Health does relative to building out an intelligent medical home, telehealth platforms and things of that nature are always looking to integrate. How do we identify that person? Because it has to happen ubiquitously across that continuum of care. So it's a very, very critical topic. I don't know if you want me to go further in that, but there are ways in which we're looking at how we capture that identity in the home, so that when you step on that scale, even we know that, and passing that data off to your care team, we know it's a specific individual versus someone else getting weighed, if you will.
Gotcha. Generally, when I go on the scale and I see the weight, I was hoping it would be somebody else's weight.
Yeah, this is true.
I'd rather not. So much perfection in that identity. Jake or Frank, maybe Jake, because you've implemented a program recently. Let me start with you. And then, Frank, I'll start with you on the next question we have from the audience. Jake, any things you're seeing so far in terms of remote care, telehealth, and how your identification system has worked with those things?
Yeah, well, so we're in a rural setting up here, so telehealth is starting to really get on everyone's radar. We do some of that already with our the Gene Upshaw Memorial Cancer Center, where we work with UC Davis and some other hospitals with cancer treatment. But we're really starting to look into tele-ICU, telebehavioral health, those types of things. So, as we move forward, if you're doing it from your phone, usually with the computers in our pockets nowadays, there's pretty good identity management with those. But to echo Tom's statement, without kind of that national ID to link those devices to that and only that, then it's still going to be a little murky. And even the laws between states and telemedicine are murky. So hopefully maybe this could all coincide with a national push towards regulating this and pushing towards a patient safety identifier would really kind of be go hand in hand with this.
Great, thank you. The next question we have from the audience is there a playbook, a best practice playbook that CIOs should be using to address patient identity problems? And Jake, why don't I start with you, just because you've worked on this issue most recently, and then Frank, get some of your thoughts, and Catherine and Tom's. So again, best practices for patient identity, and you don't have to go through the whole laundry list, but Jake, if you were to come up with 3 to 5 best practices, or 1 to 5 most important things to do, could you share those with us?
Well, first, there's a great guide. Healthit.gov kind of has, it's called their SAFER guide, SAFER. I wonder if I can post the link right here. Maybe. So this is it's a PDF, and it's kind of a self-assessment that breaks down kind of where in your chain of, as you enter your system, and gives you recommended best practices. Those types of things would be, if you're having a human do it. So all of these things are great, but if a human has to make that decision at the end of the day, you're going to get duplicate records. That's all there is to it. So, best practices clearly is giving, putting a token in place. Even when you start that program, not everyone's going to use it. So really educating your frontline staff, one, to understand what the ramifications can be, not only on the billing and fraud and those types of things, but the patient safety. I think that hits home best and really helps people remember what they need to do and be diligent when they're making these matches on the system. I think that's probably, if there's any advice, that's the first and foremost I can give anybody, is really to drill it into your patient registration, folks, where 92% of these things occur, is that this is a very big safety issue, and that usually works best for us.
Frank, any thoughts on best practices for patient identity?
Yeah, I mean, I think, first and foremost, it's old school stuff, working with frontline staff, as was just stated, because that's where the majority of these errors occur. I think anywhere you can incorporate, dual factor authentication like palm print, which is something that's used at St. Peter's, in addition to several other forms of ID, to try and get a good determination as to a patient being who they say they are. So I think dual factor, again, which we talked about earlier, big education of frontline staff as to the ramifications of errors and the best ways to prevent them. St. Peter's also did some studies relative to watching the tasks associated with these, kind of like the old G.E. Hawthorne studies, and came up with reports as to what led to the most mistakes, and then try and again incorporate that into training and best practice to reduce. But a lot of it is just, old-fashioned, nose to the grindstone work with the frontline staff.
And Catherine, you're in the business of patient identity, as I understand it. Any of your thoughts on best practices here?
So if there's any, real techie people on the call and you want to read something really detailed, I would recommend the NIST documentation, specifically NIST 800-63-2 and -3. Version 2 is the current version. Version 3 is the latest draft version. But these are documents promulgated by NIST on the correct way to do identity and to do strong identity and all the steps involved with identity proofing, with the right authenticators. It talks about two-factor or multi-factor authentication. Yes, it's very detailed, very nuanced, but that really is a great source document if you really want to learn more about this.
Could you do me a favor?
Yeah.
Some of us, I think that the audience might guess, many of them, of course, know exactly what you're talking about and can get right there because they spend so much time in the area themselves as CIOs and leaders. Other of us, some of them at smaller systems, some at larger systems, and some that aren't quite as directly connected, wouldn't get that reference as clearly. So could you do me two favors? Could you repeat the reference exactly as well as you can so people could find the reference to what you're referencing? And then two, if you have any thoughts, because you've had probably as much experience as anybody at this, your 2 or 3 best practices that you see right now, and you might say it's just so much better to read the reference you're talking about. But if you had 2 or 3 thoughts, and it might be that your best practice is to read this reference, but if you could repeat the reference and then, if you're okay with it, give us your best couple thoughts on this.
Sure. So the reference is, and I'm going to paste a link to it in our comment space, but it's NIST, which is NIST, which is our National Institute of Standards and Technology. They're a piece of the U.S. Department of Commerce. This is one of those places where our tax dollars goes. And they do all sorts of weights and measures and standards that are used in the United States. And they have a guideline that's called 800-63-3, which is the current version. That's the draft version. They have an older version, which is 800-63-2, which is the version that has been in use for some time. And if I was going to pick anything from these guidelines, because these are not things that you just sit down and read at the beach, or maybe you do, but they spell out what you need to do when you identity proof someone. That's number 1, is identity proofing. How do you know this person is who they say they are? And it's not just, well, they seem to have an honest face. It's inspecting their driver's license. It's doing verification through like credit bureaus or organizations that do identity proofing and address checking. So it's that whole world of identity proofing. And then it's the tokens, otherwise known as the authenticators. What's a good, strong token? Using just a little piece of slip of paper, that's not a good token. Chipped cards are they're smart cards, excellent tokens. So it talks about the different token types and the way that they should be applied in a workflow using multi-factor authentication. So it's a very detailed recipe for how you put this together. And if you are in this space or you're looking to understand it better, that is really the Bible, I would say, in the United States for how to do this right. But I'm going to send the link here in the chat screen. If I can paste it here. Yep. And if you all see that, you can link to that. And either you read it or give it to someone else in your organization and tell them to read it.
Thank you. Thank you very much. Tom, I've got one more question I wanted to ask people. But before I went to the next question, I wanted to see if you wanted to add something to this discussion on best practices.
Yeah, thank you. I would suggest if you go to the ONC website, they have the interoperability roadmap. Within the interoperability roadmap, they provide a high-level view of how to go about doing identity proofing. They certainly reference NIST level assurance 3 as the ultimate objective. And they also talk about how they want to reduce duplicate records down to 2%. So that would be a good starting point, understanding the ONC roadmap on interoperability, because they do incorporate patient identity into that construct. And then it's the rest is really a process of embracing other technologies on enacting the constructs that Catherine talked about and others. Is that, okay, I did my identity proofing, how can I repeat the process? I don't want to identity proof them every time they come in, so hence why the token is important. So so now I take that token and map that to a medical record, and now and then I share that medical record with that token as being an embedded identifier. That's how we get to deterministic matching. So going down that process would be a best practice.
Can I ask you a question on tokens? In a system, do most parties use one standardized type of token, or is it different kinds of tokens for different patients?
You could use we recommend one token type in a health system, but if you're using biometrics as an example, biometrics is not a forgiven. It has its pluses and minuses based on specific demographics and environmental conditions. So you could use a multitude of tokens if you needed to in order to identify that patient.
So typically you're going to have a couple different ones that the
Yes.
system uses just almost by necessity, but the more you could standardize and reduce the different types that you could use, the better without getting in the way
Absolutely.
of patient convenience. Got
Absolutely.
it. Jake, let me ask you this question, because this is something I've heard you talk about before, a little bit about the loyalty card and how that works. I think you guys have a term for it, the blue card or something like that. Could you explain that quickly?
Sure. So we have a total health and wellness program that we implemented. We call it Blue Life, kind of based on blue zones, and we're up in the Tahoe area, so the color blue resonates with our local residents. And we were able to basically brand the card Blue Life, and it comes with a smart chip. And we're in the process now of working through our data. So we have an app that we publish. It's free, and our local users are in there, and they're putting in their preferences and what they like to do and what they're working on health-wise. And we're able to identify, say, a person that's working on reducing their cholesterol. So our goal is to get with local restaurants and health food stores to offer discounts with the Blue Life program, put our logo on the menus. Here's the low cholesterol lunch of the day or the meal of the day. We also want to focus on our local healthy options like gym memberships or challenges that we do, walking challenges and weight loss challenges and things like that. But it's all tied back to that card where folks can have a tangible thing in their purse or their wallet to basically use at our local establishments, where we can further generate good buzz around our brand and be a health partner as opposed to a place you show up when you're sick.
Gotcha. And it's another way of really, connecting and bonding with your patient population, and almost like they've got their, Chase card or their B of A card or whatever it is, their gym card. You want them to have their health system card, so they're really thought of as a connection and a membership, and it serves a real purpose in terms of patient identification as well. I mean, a real purpose. But it's another bonding and branding and trying to connect with your patient population, it sounds like.
Yes, sir.
Well, this is just a terrific call, and I tell you, through the substance of the call, I think one person dropped off through the entire part of your guys' dialogue, which I view as a great job of providing good information, an interesting subject, and keeping it moving along well. So thank you. I want to thank our four panelists: Jake Dorst, the CIO and Chief Innovation Officer at Tahoe Forest Medical District; Frank DeSanzo, who I know well, who recently served as Chief Information and Strategy Officer with St. Peter's Healthcare System; Tom Foley, just a pleasure to have you on the phone, Director Health Solution Strategy with Lenovo Health; and Catherine Schulten, also just really at the front line of this. So thank you so much for your comments. Vice President and Product Management with LifeMed ID. it's great to hear the level of expertise and combined with practical on the in the trenches work that Jake and Frank have seen in this project as well. So just great. I also want to thank, of course, Lenovo Health for and Intel for their involvement in this and their sponsorship. And finally, probably as important as anything, is to thank our audience who just did we appreciate you listening in. Hopefully you learned something, got some new perspectives on some of these issues, and just a great group of speakers on this. So thank you, folks, very, very much. I'm going to wrap up because we're at 2 o'clock, and I always ask to make sure that we wrap up about 2 o'clock. So just terrific. Thank you, folks, very, very much.